Welcome to the Ty Beal Show, where we discuss food, science, and life. I'm Ty Beal, a scientist at the Global Alliance for Improved Nutrition, or GAIN. My guest today is Dr. Gordon Guyatt, a renowned clinician-scientist at McMaster University, who coined the term evidence-based medicine. Dr. Guyatt has published over 1,800 publications which have been cited more than 600,000 times. In our conversation, we discussed evidence-based medicine, why assessing evidence quality matters, the challenges of nutrition research, and how people navigate health information in an age of influencers and AI. A quick note before we start. This podcast is separate from my role at GAIN. Okay, let's dive in. Dr. Gordon Guyatt, welcome to the show. It's great to have you.
Thanks very much. Pleasure to be here.
So your scientific publications have been cited an incredible number of times. I was looking this up yesterday. As of last night, it was 643,543 times. And when I checked this morning, it had an extra 200 citations. So your work is quite popular among scientists, and you, of course, coined the term evidence-based medicine. So to get started here, could you tell us what evidence-based medicine means and what does it entail?
So I like to think of evidence-based medicine having three fundamental principles. One is that some evidence is more trustworthy than others, and one can come up with standards for deciding what is more trustworthy than others. Second, once you've decided an individual study meets standards of trustworthiness, you need to do a systematic review, which also meets scientific standards, to get at the best available evidence, because you don't want to pick and choose individual studies that match your particular interests or preconceptions. You want an objective look at all the relevant best evidence. And the third principle is evidence never tells you by itself what to do. It's always evidence in the context of patient values and preferences. So there are always trade-offs between desirable and undesirable outcomes, and people value those outcomes differently. And people with different values for outcomes may make different choices with the same evidence. So what follows from all this is that we need systematic summaries of the best evidence to guide clinical care, and that clinicians also need guidelines to help them with the interpretation and how to handle that evidence. And those guidelines should distinguish between strong recommendations, which are just do it because the benefits clearly outweigh the downsides, or vice versa, or more frequently, conditional or weak recommendations which say patients are going to differ in their choices, even looking at the same evidence, and we need to consider patient values and preferences in tailoring the decision to the individual patient.
And a lot of decisions and guidelines are made with very little evidence or without really a systematic approach to that evidence. So what you've done is really systematize this and put in a framework. And in particular, you've helped found the GRADE approach, which is a systematic framework for assessing the quality of the evidence and the strength of recommendations. So kind of along the lines of what you're talking about. With evidence-based decision-making, this also includes for systematic reviews and for policy development across multiple disciplines. So with this whole process, can you give an example of when a failure to consider the quality of the evidence has led to misguided recommendations?
Sure. So for instance, one that was famous for a long time, it's kind of fading from memory, but it's still a great one, is that if you go back 20 years or so, there were observational, that is non-randomized studies, which give lower quality evidence, suggesting that hormone replacement therapy is great for lowering cardiovascular risk in postmenopausal women. And guidelines came out saying use hormone replacement therapy. Tell your patients, tell your postmenopausal women that they should be using hormone replacement therapy. And worldwide, lots of primary care docs in particular started to do that, only to find later, when the randomized trial was fortunately done, that there was no cardiovascular risk reduction and a probable increase in breast cancer. So probably that, well, certainly that recommendation was a bad idea. And had people understood, had the principles of evidence-based medicine been well established and followed when that happened, when all we had was the observational non-randomized studies, the message to the patients would have been, maybe this is going to lower your cardiovascular risk, or maybe not. And maybe it's going to increase your breast cancer risk, maybe not. And considering that, are you interested in using hormone replacement therapy? And some women may say yes, and some may say, with you just told me, no thanks.
So it's kind of giving more informed decision with all of the available evidence. Can you say today, with this specifically, with hormone replacement therapy, has the evidence landscape changed over the last couple of decades now? Where are we at currently?
Yeah, it has. And and I don't know the evidence in detail. I don't take care of, that's not something that I give advice to women about. But my understanding is that the current thinking is that, particularly short term, for dealing with postmenopausal symptoms, that it might be a good idea. And the values and preferences are that women who try it and find symptomatic benefit may say, okay, I'll put up with the increased breast cancer risk because it makes me feel so much better.
Mm-hmm. Sort of the trade-offs you were talking about.
That's right, exactly. So forget it. Don't do it for reducing cardiovascular risk. But if you feel sufficiently better doing it that you're ready to put up with the risks, go ahead.
Mm-hmm. Well, in kind of related to this, but a bit different, in the nutrition field, we have seen a lot of scientists kind of criticize the GRADE approach for rating most nutrition evidence as low or very low, which is really due to the challenge of meeting the quality guidelines in GRADE. So this sort of challenge of having long-term randomized controlled trials where people are blinded to their diets, we can't do that, certainly can't do that for decades and observe effects on diseases like cancer or heart disease. Do you have any sort of feedback to the different approaches that have been proposed around nutrition? Do you think that there needs to be subject matter specific approaches, or does GRADE kind of cover everything?
Well, I've just told you about one time where the non-randomized studies turned out to be misleading. I'll give you another one, nutrition related. So that for a while, everybody thought, on the basis of observational studies, that antioxidant vitamins were great for both reducing cancer and reducing cardiovascular disease. And there were large, nicely done observational studies that suggested substantial reductions in cardiovascular disease and cancer. Unfortunately, when the randomized trials of antioxidant vitamins were conducted, there was no reduction in cancer risk and no reduction in cardiovascular risk. And there were, for some of the antioxidant vitamins, adverse effects. So it would have been a mistake to pretend on the basis of the non-randomized studies that we were really confident. We weren't, or at least we shouldn't have been. And to say, well, in nutrition, we're going to pretend that those observational studies actually gives us high quality evidence. For other things, no, you can use the GRADE standard, but we're going to pretend for ours that we're getting high quality evidence out of this. Probably not a good idea. People may need to make dietary choices, no question, and they need to look at the best evidence. But they need to acknowledge it's only low quality evidence, and people might very well make different decisions if you know something is actually true versus maybe it's true, maybe it's not true.
Mm-hmm. And oftentimes, the randomized controlled trials actually contradict the observational evidence. So that's sort of like leaping ahead and trying to pretend like we have more confidence than we do.
Yeah, and that is the case in the examples I just told you.
What about with a specific guideline like NutriGrade? I don't know if you're familiar with that
Yeah,
sort of
yeah. Well,
suggestion.
I am somewhat sympathetic. If I were working in nutrition, or a lot of public health folks have this, you think, oh gosh, we're only going to have low quality evidence. We'd like to sell our results. We'd like people to do things on the basis of our results. Geez, it's only going to be low quality evidence. Well, let's make up a revised system that lets us call it moderate or high quality evidence. And that's what NutriGrade does, as I understand it. But as I've just told you, understandable, somebody might want to do this, but I don't think we're serving our patients or our population well when we tell them we're confident about something when we shouldn't be.
Mm-hmm. And it's sort of like lowering the bar for what gets considered higher quality or higher certainty evidence.
That's right. That's exactly right.
Well, you are also a part of something called NutriRECS, which was in 2019, a series of papers in the Annals of Internal Medicine. And this was around guidelines on unprocessed red meat and processed meat. And for any of the listeners who are not aware, this was really unusual because it was actually attacked before publication by a very high-profile scientist. Can you explain what happened there and why?
Yes. So what happened was that it was actually very unusual that one of the more prestigious journals published 6 articles from a single group in a single publication. But the Annals of Internal Medicine decided that what we had done was of high enough scientific integrity and of interest to their audience that they were ready to publish 6 papers from our group in the same publication. However, the word leaked out that this was going to happen, and it really upset people. And the reason it really upset people is we said, there's only low quality evidence about the adverse effects on patient important outcomes of eating meat. And indeed, even if there is an effect, it's really small. And we also did systematic reviews of people's values and preferences. And so there've been some studies about people's values and preferences. People like their meat, and they think it does all sorts of good things for them. And there's traditions that make them want to continue. And bottom line is, people, our interpretation of this is that most people, or at least the majority of people, knowing that the evidence was uncertain about any harmful effects of the red meat, and if there were harmful effects, they were likely to be very small, that the majority of people would say, knowing that, and for the reasons I'm attached to my red meat, I'll just continue eating it. And so we made a weak or conditional recommendation, clearly value and preference sensitive. So yes, our view was that the majority of fully informed people would say, I'm continuing with the red meat, but there would be a minority of people who would say, no, I'm worried this might be harmful. I'd prefer to stop. So a conditional recommendation in favor of continuing with red meat.
Mm-hmm.
For the nutrition community who had presented these observational studies as giving high quality evidence, and gone further and suggested everybody should cut down or stop taking red meat, they were very upset at what we were saying. Mm-hmm. And as a result, they launched a campaign before publication to stop this. and the editor of the journal had 4,000 emails on the day it was published, completely jamming her emails in a little attack of sabotage. And so it was an unpleasant situation.
It's unprecedented to have that occur, and it was very intense. And I remember reading an article about it, about sort of that process behind it, and just being sort of shocked. But at the same time, I guess it makes sense. People are very passionate about this issue, especially with this increased effort to try to make the more sustainable diet or the planetary health diet, and recommending very low intakes of red meat, right?
Yeah, and we, in our recommendation, it was some years ago now, where the evidence wasn't about the planetary health issues, was at least, well, I would still say it was not as strong as it is currently. And secondly, we didn't have expertise in that area. So our team wasn't equipped to look critically at the evidence. So we specifically said people may take planetary health issues into consideration. That is not part of our recommendations. We left that out of our recommendations. And if we had taken that into account, then things might have been different, particularly, but I'm not sure they would have, because if we had said to people, now consider there may be some planetary health issues here in your red meat, where I'm not sure how many people would have said, oh, yes, I really care about the planet. Even though I love my red meat, I will cut down or stop. I'm not sure what they would have done. The evidence isn't available about that, as far as I know, even now. So anyway, that was, but I, it's speculative as to what drove this. I do not think, I think it was, we were challenging fundamentals of the nutrition community's way of operating, which was, as far as I can see, as I characterized it, to pretend that their low quality evidence was high quality evidence, and then start telling people what to do, imposing their own values and preferences rather than people's values and preferences. And those are two not so great things in our view that are going on in the nutrition community, and our guideline challenged those head on. I think that's what drove the reaction.
Yeah, and I agree. I think the evidence is, when I've looked into this, it is really sort of uncertain and low quality, and there's an exaggeration by some researchers, and I think you sort of put it pretty correctly, that the status quo, or the dominant view, whenever that is challenged, there is a lot of pushback against that. What you highlight about feasibility, or in terms of preferences and traditions, is really important, because even regardless of the evidence, which I think there is a lot of debate about, the reality is that currently people want to eat a certain amount of meat, and it's much higher if people can afford it around the world than something like the Eat Lancet suggests. Do you know, looking at this sort of evidence landscape over the last 6 years, has anything really changed from your understanding? How sort of certain should we be about these recommendations that are out there that say there's a dose response relationship, where the higher the amount of unprocessed red meat, and of course processed meat, there's an increased risk? Has anything really substantial changed from your understanding?
No. It's low quality evidence, and as I said, even if it's true, it's very small effects.
Yeah, and I think what's also fascinating is to think about which outcomes are actually being considered. And of course, we know that there's a lot of nutrients of high value and bioavailability in, for example, unprocessed red meat, like vitamin B12 and iron and zinc. And when we look at a lot of the evidence, those are some of the top sources, unprocessed red meat, of those nutrients, but they're rarely sort of considered in the studies where they're trying to look at a tiny change in diabetes or something. So I think it is a bit of a challenge there with what's out there. Okay, so moving on, let's talk a little bit about the sort of health information environment or the health influencer environment. So we already know there's quite a bit of an issue around the health and nutrition space in the scientific community. And I can imagine among influencers who have even less training, oftentimes, not always, there are recommendations being made all the time with even far less rigor than what's out there in the scientific community. So these influencers are really one of the most, I think, influential ways that people make decisions, especially health conscious individuals. And looking on social media and podcasts like we're recording right now and others. Do you sort of have any thoughts about how does this compare? Like, what is the range of evidence quality that people are using to make different recommendations? Because regardless of whatever people think about the evidence, the most influential people are often not actually trained as in any sort of science or research background.
Well, you're taking me outside of my field of expertise, and you should take that into account. So presumably you're making statements about the way things are. I've not read any systematic reviews of who makes the recommendations and their background and what recommendations they make. My impressions of the situation are, which should not be taken too seriously since I don't know the evidence, but my impressions of the situation are, yes, that lots of people are getting it wrong in terms of the quality or certainty of the evidence and making statements that do not capture the uncertainty, and as a result are misleading. That's my impression.
Yeah, and I think what you did there is kind of a testament to your, I think, your sort of expertise is that you summarize the nature, like for your whole career, you've really looked at the quality of evidence. And so when you are talking about something, you're very clear to sort of disclaim or sort of qualify what you're basing your own sort of opinion on. And I think that's sort of lacking in a lot of these fields for sure. A lot of these sort of influential figures.
When I tell people about evidence-based medicine, I say at least one of the fundamental principles of evidence-based medicine comes a long way before evidence-based medicine. And it's Confucius talking to one of his students. And he says to his students, you know what real knowledge is? To know when you know and know when you don't. Mm-hmm. And you're right. I actually enjoy it when often when I'm giving talks and it comes to the question period, there's the first several questions are address things that I actually know something about. And then somebody asks a question like the one you did about what's going on in society and so on, where I have where it's way outside of my area of expertise. I don't know the evidence, and I regularly answer just the way I did there. Sometimes I just say, sorry, I don't know. That's it. Next question, please. Mm-hmm. Sometimes I may, but if I do express a viewpoint, it is with the qualifier that I just gave you.
Mm-hmm. And I think a lot of people want to have an answer for things. And so that's why I think there's sort of a tendency to just sort of answer with opinions, perspectives, or whatnot, or what works for people without really them understanding. So obviously there's a big range of quality of the evidence that's out there. Can we talk a little bit about AI? Not sure if you've had much experience or looked at the literature at all, but do you have any thoughts about how AI is sort of influencing the evidence-based sort of decision-making landscape for researchers, clinicians, and the public?
I've been involved in some AI-related activities, making up. So, for instance, I'll tell you the one where I actually know something. So that the bots are providing health advice. They're providing health advice not only to patients, they're providing health advice to clinicians. And some people appropriately are saying, we'd better look at what these bots about whether they're giving good advice or they're not giving good advice. Unfortunately, we did a systematic survey of these studies, and these studies are bad. In other words, the studies assessing whether bots are giving good advice are low quality studies that you can't trust their conclusions about whether bots are giving good advice or bots are not giving good advice.
Mm-hmm.
And so we, to try and remedy this situation to some extent, brought experts in AI, experts in methodology, other relevant experts to come up with a checklist of items that should be included in all these reports and frequently are not at the moment. And there was actually a lot of interest. A whole bunch of journals co-published our checklist at the same time. So bottom line is this is something I actually know about, that people are looking to for advice. And at the moment, it is still uncertain how much of the time they're getting hallucinations, or that the information, as you've just pointed out, there's lots of misinformation around. What you may get, if that's the most of what's out there, what you might get from the bot is this misinformation. So, and there are people, including a group I'm working with, that is studying how to get better information. And our notion and what we're working on is it all has to do with your prompts. So a doctor may say, should I encourage my patient to have colon cancer screening? God only knows what they're going to get. If they say, I'm interested in the latest trustworthy guideline that uses the GRADE approach and looks at outcomes that are important to patients, can you tell me what that guideline suggests to me?
Big difference.
There's a big difference. So so our notion is that down the line, we are going to have courses for physicians on prompt engineering, how to make your prompt so that it will actually give you an answer that you can trust. And we're working on that at the moment. So so right now it's Wild West, but we're thinking that the optimal use will involve learning how to give prompts that give good answers.
Mm-hmm. Okay, so there's still a lot to be done in terms of what items should be included in reports, and how do you actually build the evidence base and make higher quality studies.
Well, we think we've answered the items that should be in the reports. We put out our checklist. If people listen to that, if people pay attention to it, the right things, they'll at least report the right things in the. It doesn't guarantee the studies are well done, but it would move. But if you report, obviously, if you tell them, please report this, and this, that it moves it in the right directions.
Right. So it's available, but that has to be actually implemented.
And we know from previous research, like people have put out what to report in randomized trials, what to report in systematic reviews, what to report in observational studies. That doesn't mean anybody follows it. So the adherence to these checklists has historically been limited. Mm-hmm. It's getting better, I think, but historically it's been limited.
Yeah. And what you also mentioned is framing the question makes a big difference. And I think having a really intelligent sort of question that grounds it in something like a framework, for example, GRADE, is going to produce a different response for sure. Have you had experience asking any of these large language models questions that you are very sort of confident in the answer or the literature of? Have you sort of just in your own experience tested that out to see how they respond?
For better or worse, I have no interest in playing with AI. And despite the fact that I'm involved in research about AI that I've just told you, I don't use it. I have what I think are good sources of evidence, and I don't think the answer or the most important insights would come if I did it from my playing around. It's like anything else, it's got to be addressed systematically.
Mm-hmm. I have used AI in some processes to sort of streamline the data extraction process of a systematic review, which I think can help, but it's not coming up with new stuff. It's just sort of like helping shorten the time it takes to do
Yes.
things.
Oh, it should be able to do that. So my students aren't using it yet, which makes me think that that it still leaves something to be desired. But down the line, you would think it could get very good at streamlining that process, and that's if it does, that's unequivocally useful.
Right. So you've sort of highlighted on a theme that I think is important to mention again here, is that it's important to be able to know what you don't know and to be okay with saying that. I think there's a lack of, I don't know if it's humility or pressure to sort of know things. Oftentimes there's, like you said, there's a lot of sort of bias, or there's maybe vested interest, even if it's just personal researchers having their views and they really are passionate about them. And there's this tendency to exaggerate or hype up certain confidence in things. I think one of the things that I really appreciate about you is that you're sort of stating the confidence, the certainty as it is, without sort of the hype or any of that. And I think that's super important, especially in nutrition, where, as you sort of pointed out, the evidence is very low quality in general. It's very hard to get higher quality evidence, and we can't, we can, but we shouldn't just create new frameworks that allow us to call the low quality evidence higher quality just because our field doesn't have the types of studies necessary to really get to the very high certainty of evidence.
Couldn't agree more.
So you've had this amazing career, and centered around evidence-based decision making. Is there anything that you would advise the next generation who are interested in this and who really care about getting this right? The science of understanding, how can you know what you know? How can you appraise the quality of evidence? What is the future for this area?
Who am I giving advice to? Patients, clinicians, researchers?
Yeah, how about researchers and clinicians?
Okay. For clinicians, clinicians are not going to be able to make the assessments of individual studies, even of systematic reviews themselves, nor even if they were able to do that, might they be aware of all the contingencies that expertise might bring to interpret the evidence. So as a result, clinicians need guidelines, and they need trustworthy guidelines. So for any clinician, I would say you need to find, for in your area, whatever it is, one or more sources of trustworthy guidelines that you can use. And then you need to be, if you're going to do shared decision making, you need to be able to understand the results. So you need to be able to differentiate between a relative effect and an absolute effect. You need to be able to tell your patients about the best estimates of the magnitudes of effect. And you need to understand the notion of certainty of evidence, that some evidence is more trustworthy than others, and to when people tell you, well, here's our best estimates, but there's only low certainty, you need to know what that means and what the implications are. So that's what I would tell the patients, or the clinicians rather. What I would tell the researchers is, we need to get high certainty evidence. It's tough to do big randomized trials in nutrition, but they have been done. And if we could persuade governments, which might be more difficult in the current environment, where in the United States anyway, all the resources that could be devoted to such a thing are decreasing rather than increasing. we could run, and there have been some large randomized trials of alternative nutritional approaches that allow us to find out what the answers are. And eventually it would be possible to have high certainty evidence. It will take resources, excellent planning. It might take it might take another thing that we should be doing is trying to get the public to understand what uh, what we need to be confident, and so encourage participation in such trials. But as opposed to throwing up our hands and say all we'll ever have is low quality evidence, it's not going to be easy. But areas like nutrition, it is possible, need to mobilize to do the studies that actually would give higher quality evidence.
I totally agree. It sounds at least hopeful that there is a possible way forward in getting this data. You mentioned as governments, and I think maybe private sector donors could play a role, but governments really have the largest budgets to fund this type of work, and so there needs to be this. Yep.
And you need to have so. With drugs, you don't have to worry about the government because people can make a lot of money with new drugs. So pharmaceutical. Nobody's going to make a lot of money out of particular nutritional approaches. Well, I suppose maybe that's just the limit of my imagination. Maybe somebody would make a lot of money, but but off the top, it seems unlikely. In which case, things have to be funded but from the public purse.
Yeah. And we have to actually get the leadership to be able to make those decisions and the public to understand what's necessary.
Yes.
So that's at least it's possible. We'll wait and see. I hope that that's the case. But, until then, I think that we need to be cautious about giving recommendations. Do you have any sort of final thoughts on how do we pursue nutrition recommendations when there is such little evidence right now?
We need to communicate uncertainty. To me, if you were saying when the developing the drugs and the vaccines in COVID went spectacularly well, and coming up with guidelines about drugs and vaccines, although there was obviously a lot of misinformation, but if people were ready to listen, we did very well. Public health did not so well. And what's the major problem with what public health did? They did not acknowledge the uncertainty. And so you're right. People like to say, tell us what to do, but we're not serving them well if we say, you want to know, we want us to tell you what to do, we'll tell you what to do. Unfortunately, what we're telling you to do may be wrong, but we're not going to say that. So the big thing is to acknowledge the uncertainty. That is, and I had on a prior interview, somebody quoted some public health person that said, "Oh, we have low quality evidence, but sometimes we have the instinct." And my reaction is, what nonsense. You have the evidence, and then what you do is to point out the underlying values and preferences that may gear toward making one decision or another. So if you take the red meat, if you are a person who loves your red meat and is appropriately skeptical about the downsides, if you're somebody who isn't attached to your meat and you want to do everything in your health, maybe it won't help, but maybe it will. If you're that sort of person, you're going to give up your red meat. So that when there's low quality evidence, the other job we can do is to say, here's a constellation of values and preferences that would lead to decision A, and here's a constellation of values and preferences that would lead to decision B.
Yeah. It sounds like there's just been a huge disconnect from the science and then the public health aspect of it. And there's been an assumption that, oh, people can't understand this, so we're just going to communicate it with a really high certainty because we know what's best for people. And I think that loses trust. And we've seen that in different ways, that's lost trust in.
I agree with that. Although, once again, I'm not a political scientist or a social scientist, but my intuition is you're right.
Yeah, I think we hopefully we'll see some more, a bit more transparency around acknowledging the uncertainty and what we don't know, and give people a little bit more ability to make informed decisions where they can consider the evidence, the preferences, values, all of that together. So, Dr. Gordon Guyatt, thank you so much for speaking with me. It's been a pleasure.
You're very welcome. Been my pleasure as well.